Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting.
And I'm Dr Maria Bolton, GP and former President of the Australian Medical Association of Queensland.
And we're coming to you from Meanjin, the land on which this podcast is being recorded. Today we're joined by Dr James McAuliffe, Mater's child and adolescent psychiatrist.
James spent 2 years in central Queensland as a rural general hospital doctor before qualifying as a paediatrician. He went on to train as a psychiatrist and now specialises in the mental health of children, adolescents and young adults, with a special interest in ADHD and ASD.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
James, welcome to sMater.
Thanks for having me.
Today we're tackling the hot topic of ADHD, and we appreciate it can be a complex area to navigate. Firstly, if we can start with how ADHD presents differently at different stages of the lifespan, adults and children.
The initial and most obvious presentation is when children hit school, and it's the hyperactive, impulsive child who cannot sit still in the classroom, who cannot contain their excitement, their behaviour, their frustration. So I think the initial presentation is the sort of presentation that people are very familiar with. It's the stereotypical ADHD child. So I think that pathway, is quite well worn and well trodden over a lot of years. I think the thing that's shifting as we become more aware of ADHD is the children and teenagers who are older, who are not hyperactive or impulsive, but are particularly inattentive, disorganised, and unable to reach their potential. And so I think what's happening beyond that initial more stereotyped classic presentation is that there's an increasing awareness that just because you're not naughty, or just because you're not misbehaved, or just because you're doing well in school doesn't mean you can't have ADHD. And I think what's shifting is that people are becoming increasingly aware of that and starting to come forth and say, look, I can't keep my mind on what the teacher's saying. So I think that's the newer presentation when people are older and in their later years of school. And I'd say something very similar is happening with adults as well, where there's an increasing awareness, and it's those sorts of problems in adults who become aware via social media sort of posts, or even their adults becoming aware via family members, particularly their own children, getting assessed, teachers suggesting things, and then in the course of interviews and assessments are mentally thinking, I did that, or I do that, I still have that, I've always struggled with that. So I think that's the shift that I'm seeing with ADHD presentations.
And people being more open to seeking support and help.
Exactly, yeah, and it's not sort of something that, the sense that this is me, I just have to put up with this. There's nothing that can be done about this, and sort of some pretty negative views of yourself that have been internalised because that's all you've ever known, and you wouldn't have thought, hang on, this is a diagnosable developmental disorder that can be treated really quite successfully.
James, there's no straightforward diagnostic test for ADHD, but are there some useful diagnostic tools that GPs may be able to use?
You're right. I mean, ADHD is a diagnosis that has an enormous amount of subjectivity involved to it. It is defined by a set of criteria that none of which are measurable. So I would recommend, there's a number of quite freely available standardised questionnaires. So they're usually based on the DSM criteria. So the ones that I would recommend would be something like the SNAP-4. 4 with Roman numerals. There's a Vanderbilt questionnaire out of the States that's been around for a long time. There is ASRS is another one, the ADHD self-rating scales. And there's also sort of various apps that are available. There's one, I think, through the ADHD Professionals Association. So I'd recommend sort of GPs getting hold of one of those freely available standardised questionnaires and administering them.
According to the Australasian ADHD Professionals Association,
ADHD is now the most common neurodevelopmental disorder in children and adolescents in Australia, affecting 6 to 10% of children and adolescents. It also indicates that the best estimates of prevalence in Australian adults is between 2 and 6% of the population.
A Senate inquiry into ADHD in Australia heard that expert care for children with ADHD is in such high demand in the public system, and I would add private system as well, that there are extreme difficulties in getting access. This is not news to us GPs, with our patients facing long wait lists, both public and private, and of course it's worse outside metro areas. For GPs who are looking to refer children for more specialised care, particularly here in Queensland, what are the options available and how difficult are they to access? And perhaps if you can also touch on those available for rural areas as well.
So look, I mean, you're spot on when you say that there are long lists and there is no easy access to care for these services, as there are for a lot of specialised services or specialist services in Queensland. So look, I think your local public paediatric services, I think, is probably the most common pathway with respect to public. Public child and youth mental health, as a rough rule, does not see and treat ADHD if someone is referred for that specific reason. If they're seeing someone who has another mental health disorder who also has a diagnosis of ADHD, they will treat and manage that. If they're seeing someone for severe and complex issues there where they think, hang on, I think part of this is ADHD, they will initiate treatment. But largely the mental health public side of things does not touch ADHD in Queensland. Privately, I think you then obviously have both the psychiatry and paediatric services. What's emerging more recently are some telehealth options, which I would suggest would be good options for people who are living regionally and remotely. There are some paediatric services that do fly-in, fly-out clinics to these more remote places, which could be an option. And there's also starting to emerge some new services, both publicly and privately, that are using using GPs who have a specific interest and some extra training in ADHD with close, I'll say supervision and input from either a paediatrician or a psychiatrist who are then able to see, assess and manage a lot more patients when it's not all down to one specialist.
What are some of the things we need to watch out for when you have a child with ADHD transitioning to adolescence and then adulthood?
Yeah. So I think a key part of that going through to the childhood to adolescence to adulthood is the medication treatment. The most effective medication treatment for ADHD remains the stimulant medications. And the stimulant medications very frequently need to be titrated up as that young person grows, gets bigger. They need bigger doses to do the same, to have the same benefit because of that increase in that person's size. So I think that's a really important thing to be aware of, is that titration over the lifespan is crucial to getting optimal management of ADHD. And a dose that used to work will not take that long to not work, particularly when someone goes through their the growth spurt, around that sort of early adolescence. The transitioning to adulthood, there can certainly be similar issues with needing high doses. Most females' height tops out at about 16. Males is a year or two later. But what is not necessarily well known is that no one's weight tops out at that age, and that all human beings of any gender continue to gain weight up to and beyond their 20th birthday. And take on their more adult shape. And that then often necessitates a change in the dose of their medication such that you can receive optimal management from that point of view.
James, it's really interesting that the 6 to 12-year-olds used to form the largest cohort for ADHD patients, but I think since 2021, 2022, the age group, their largest population, is now the adult population, so people over 18. Why is that?
So look, I think I've heard this before, and look, my understanding is that historically there wasn't this sense that ADHD was a lifespan condition. So there was a lot of children who received the diagnosis, and then it was kind of expected almost
You grow out of it or
that you grow
something?
out of it.
Okay.
So that's one part of it. The other part of it is, I think that, childhood is defined, roughly by that sort of 6 to 18 age group. Sorry, it's much younger than that, but with respect to ADHD, it's only 6 to 18. There's 12 years of your life. Whereas the vast majority of people with ADHD are treated beyond their 18th birthday, and your adult life goes for a lot longer than 12 years beyond turning 18. So there's just sheer weight of numbers that means that everyone who's a child then graduates to adulthood and then often remains in need of treatment for a lot of years, and that's why there's more adults with a diagnosis than children.
Is ADHD increasing in prevalence, or is it just that there's an increase in awareness?
The research would seem to indicate that the prevalence is probably steady. I think what is changing is very much an awareness, and I think that's probably predominantly behind the increasing numbers of diagnoses. But I think it's also something to be cautious of, that there are countries on this planet who have treatment rates exceeding 15%. And I think when that's way out of keeping with the studies that are done that look at the incidence of ADHD, I think we've got to be careful as a country that we don't go down that path. I think of treating anyone who has some features of ADHD as if they do, and prescribing the standard medications when there's probably far more complex things going on that need to be addressed.
As GPs, you often have a child who's diagnosed with ADHD, and then that child is treated and stable, and then the parent comes in and says, "I think I have ADHD." Is it because it's front of mind, or is there a big genetic link?
I think it's both. There's a massive genetic link. It really is. I mean, now, when I say genetic, I mean there has not been a gene identified where they say, hey, this is the thing that gives you ADHD or that causes it. It's more of that matter of looking at family trees and family histories and things like twin studies as well that give you that very strong genetic link, which is in the 90s percentage-wise. So I think it's very much there genetically, and I think you're spot on when you say that, hey, look, when someone is diagnosed with it and treated with it, and then there's a greater social awareness or public awareness, it gets adults thinking, and I think that is the other significant factor behind those things, yes. I still remember one mum saying to me when I diagnosed her child and the, how would I put it, the customary major improvements that occurred. She said, you know what, I've been reflecting, and she said, all my professional life, I hired very assertive PAs who were very good at telling me what to do and when, and I followed them. Now I've gone out into consultancy and my own work, I am getting into so much trouble with my clients because I'm not getting done the things that I say I will do and fully intend to do. And so I think there's other things that sort of help people go along that I think intelligent, intuitive people understand that this is how I need to run my life. They make it happen, but things can fall apart when circumstances in life change. And it's important to, I think, not dismiss them and sort of give those people the treatment that they deserve and the assistance that they deserve, because it is life-changing.
A Federal Health Department briefing published under Freedom of Information laws in 2023 illustrated the rise in ADHD prescriptions in Australia. It reported that ADHD medication levels more than doubled between 2018 and 2022. 1.4 million ADHD prescriptions were given to 186,000 people in 2018, compared to 3.2 million prescriptions to 414,000 people in 2022. During the same period, the cost to taxpayers through the PBS rose accordingly, from $59.2 million to $151.96 million.
We've talked about the increase in ADHD and the increase in awareness. What can we do to address the growing need for ADHD diagnosis and management? What are the opportunities for GPs?
This is, I think, where it gets tough, because I think a lot of what needs to be addressed is at a much bigger sort of policy level. I think there are things with respect to, I think, GPs taking their own interest, potentially getting their own training. everyone is free to join professional associations. There's one called ADPA, Australian ADHD Professionals Association. GPs are very welcome to join that, to attend conferences. It's easy to learn through those sorts of things and get on those networks. So I think there's a lot that GPs can do with respect to their own learning, and then I think not being afraid to be involved as co-treaters with the involved paediatrician or psychiatrist, and looking out for. I think my own anecdotal experience is there's a lot of GPs who will start to look in their career for opportunities to do something a bit subspecialised. And that might be in an area of musculoskeletal medicine, or breast cancer, or ADHD treatment, or fertility. So there's a very long list. So I think that's the other avenues for GPs to become more knowledgeable and more involved.
So, James, if a GP wants to co-manage a patient, sometimes we do get a letter from a psychiatrist saying, please manage this patient moving on, but say a GP wants to be more involved, how does that happen?
Look, I would suggest two avenues. One is sort of discussing it directly with the patient and their family, saying, look, I'm interested in this condition, I would like to be involved, I would like to learn more, and I'd like to help you out more directly, because it is not a small thing to have to go and see a specialist on a regular basis for treatment of something like ADHD. And in my experience, families and patients jump at the opportunity to not have to come and see me every 6 months, and I'm happy to do that, because for my mind, it then it means I can see more people who need my input and assessment and care. So I think it's discussing it with the patient and or their families first, and then a letter or a phone call to the involved specialist, be that a paediatrician or a psychiatrist. And I think there's very few, if any, specialists who would not welcome that assistance and that interest and involvement.
That extra support, because as we know, wait times to see a specialist can be some time. So how can GPs support their patient through that time?
Whilst waiting for that assessment, I think it's the non-pharmacological aspects of management that are important. So for younger people, that is going to be finding generally an allied health professional with a particular interest in ADHD. So that is going to be spread across psychologists, occupational therapists, sometimes speech therapists, and senior nurses who might have been mental health nurses or nurse practitioners, who can engage the person or the young person or others in the sort of cognitive and behavioural strategies that are useful in managing ADHD. Because it is a very important part of treatment. As an effect size, like, it's not as big as what the medication results in, but I think it's a vital part of any treatment. So I think it's good to get that started. But those people are also going to be able to provide some really good education about ADHD. And I think whatever the significant health condition you have is, or even minor ones, people do better if they know how it works, if they know what it is and they know what it's about, and they can spot the things when they're happening and be aware and start to sort of change things themselves before they might then get into the specialist and start something such as medication treatment.
Each state has different legislation around who can prescribe ADHD medication. So can you clarify the legislation in Queensland and where are GPs getting the guidance on this?
Yeah. So look, in Queensland, the legislation is that for the under 17 age group, GPs have no restrictions around prescribing stimulant medications as long as they stick to the standard dose guidelines. Once someone's turned 18, a person basically has to continue to see a psychiatrist in order for the GP to be able to prescribe. So there's a 2-3-page form that can be found pretty easily on Queensland Health's website, sort of the Medicines Prescribing Authority for Stimulants. So once someone's 18, if a GP wants to be involved, they need to fill out that form, submit it. So it's a reasonably quick turnaround, and then that GP has permission to prescribe to that person as long as they stick within the standard prescribing guidelines, and that adult also has a psychiatrist involved who will see them every 2 years.
Every 2 years?
Is the kind of, that's the magic number, is 2 years. A GP will get approval to prescribe for 2 years, and then they'll have to return to see a psychiatrist to check that everything's happy, everything is as it should be.
James, in prescribing the psychostimulant medication, what investigations should we be doing on children before they start those medications?
Yeah, depends a bit on the health of the child. In my experience, the vast majority of children who walk through my door are otherwise healthy. So there aren't standard, I'll say, investigations. The thing that I think is crucial is more observations, and that's things around height and weight, with weight being more important because weight, I think, is a more sensitive indicator of that person's nutritional status. And you need to be making sure that the child is continuing to grow along appropriate percentile lines in order, I think, to feel comfortable to continue to prescribe. I think it's okay or appropriate from time to time to check a pulse and a blood pressure. But again, in the vast majority of people who walk through my door, they're young people with healthy hearts and no cardiovascular disease. So I think it's just the caveats to that is, does this young person have a structurally abnormal heart, history of another cardiac condition, or is there a family history of something concerning? So concerning is not someone having a heart attack in their 60s when they've been a smoker and had high cholesterol, etc., etc. Concerning is when there's a history of sudden cardiac deaths at young ages, or particularly abnormal rhythms, cardiac rhythms that could have a genetic component to it.
We discussed the need for investigations in healthy children. How about in adults that are looking to start the medications?
Yeah, I think that's where a sort of a more thorough, I'll say, examination or interrogation of more general of health status is important, particularly in the cardiovascular area. So the older a person is, I'd be far less concerned about a 20-year-old starting a stimulant medication as opposed to someone who's in their, let's just say, mid to 40s and onwards, which is happening and which is appropriate. But you've really got to look at what is this person's cardiovascular risk, what's their cardiovascular status. You want to make sure that there's not a history of ischemic heart disease or cerebrovascular disease. I think as increasingly as people leave school, you've got to, I think, be a bit more mindful of potential for misuse and abuse, and there's more adults who are presenting to alcohol and drug services than there are children and adolescents, and so I think that's one factor that you should have in the back of your mind, not in the front of your mind, because I think it's, I can go into that later, but I think it is looking at general health, particularly cardiovascular, and occasionally, I suppose, substance use when it comes to adults. They're the sort of investigations.
ADHD Australia's Senate inquiry submission dated May 2023 noted that in Australia, 3 in 10 people impacted by ADHD find it hard to get support, and 1 in 10 do not get any support. Furthermore, people with ADHD and their families view the best source of support for ADHD to be from doctors and other health professionals, followed by family and friends, Facebook groups, ADHD support groups, and website information.
Can a patient outgrow the need for medication?
They can. And this is where it gets a bit uncertain with respect to no one knows specifically what ADHD is and what is the precise mechanisms of the problems within the CNS. So look, there is evidence that with time, people's burden of ADHD symptoms declines. So with that decline, there is going to be a point for some people where they sort of then fall below a threshold with respect to the burden from their ADHD symptoms. So there's that natural decline that seems to occur. I think the other thing that occurs as you grow older and more sensible, more mature, more experienced in life, whether you got ADHD or not, you figure things out and you get better at remembering things and not being late for work and getting the washing done and paying. So that normal process that happens for everyone happens in people with ADHD, and that can then sometimes mean that the person becomes less reliant on the medication or can do without it. And particularly when you've been doing a job for 15, 20 years, you get pretty good at it, and a lot of that is second nature or you're on autopilot. But for young people who are starting work and training at university and in apprenticeships, it's often pretty crucial.
I'm sure you and many other specialists have been in that position where parents may come in and see you and have some concerns about whether their child really needs medication and questions over whether it's addictive. What do you say? How do you respond in that case?
So look, specifically with respect to addiction, there's no evidence that this medication is addictive. It is being given at very sensible, calculated doses that are there to try and switch on the parts of the brain that help you with your organisation, your planning, etc. It is never given in doses that are intoxicating, which is a pretty key part of a person becoming addicted to a substance. And there is decades worth of experience with respect to the use of these medications at the doses that they continue to be prescribed at, that it doesn't result in addiction. And I often then tell concerned parents that there's actually good evidence that treating ADHD results in a very significant decline in issues with substance use, both as teenagers and adults. With the theory being that if you have your ADHD treated, you are just odds on more likely to make better decisions in your life across a whole range of things, including your use of substances, so treating ADHD will decrease substance use and addiction issues, and that's been proven across a significant number of studies that have been borne out through even to the level of meta-analysis, that it is a good thing to treat ADHD for that purpose. And it's the kind of, you need to be worried about the opposite almost in not treating ADHD if you've got a concern about substance use.
We've been hampered by medication shortages, and it's a real shame when you have a patient who's been very stable on a particular medication. Any tips on how we can navigate that?
Yeah, so lisdexamfetamine or Vyvanse was the brand that was significantly affected in the last, maybe I'll just put it out of my mind because it was so terrible. It was 12 to 18 months ago, I think, or across the, yeah. And so that one was a little bit easier in that there were different strengths available, and from those strengths you could get that person their usual dose of that medication. The current shortages are across long or 12-hour acting methylphenidate, with Concerta being the best known brand. And it's a harder one because every strength has been affected, whereas, and is on the TGA's website is saying it's going to be affected until the end of the year. And it's just tougher to find alternatives to 12-hour acting methylphenidate because they can't be split. You can cobble together other doses, but when every strength is affected, and that's where it's sort of, I think a lot of that is the person is needing to go back and see their specialist to look at, do I switch to the alternative stimulant, i.e. do I switch to Vyvanse, or do I cobble something together from the longer-acting Ritalin capsule, which will cover you for 8 hours? So cobbling together something with an 8-hour capsule and tablets to try and give you that 12 hours of benefit that you were receiving from the Concerta.
We know that management should be multimodal. So what strategies do you think have been shown to be really effective, and are some more successful than others or better suited to a particular demographic?
Medication treatment should be at the top of the tree, I think, with respect to treatment, simply because that has been shown pretty clearly to have the biggest effect on reducing ADHD symptoms. The other forms of treatment, there's not a lot of strong evidence for them. I think it's very sensible to use them and engage with them and recommend them. But the strength of evidence isn't as great for those methods. So the next most, I think, evidence-based treatment is the cognitive and behavioural interventions for ADHD. Then there is a raft of other interventions that have probably got a significant basis in cognitive and behavioural strategies, but might be more on the family function and family therapy aspect. Working with teachers, working with exercise physiologists. So there's a whole ADHD coaches. There's a whole range of people who are involved in managing ADHD. It's just that we're yet to find the the resources, etc., to study them in a manner that would give us that confidence to make those recommendations. And the other thing that has come from studies is that the non-medication interventions that are required to make a significant difference are big and are very intensive with respect to the number of hours that are required, the number of people that need to be involved, and the expertise of the people who deliver them. And so from that aspect, it's just hard, I think, for families to find the time resources and the financial resources to really sort of give that its best shot.
We're seeing an increased number of people coming in saying they've Googled or they've seen TikTok and they believe that their child has ADHD or they may have ADHD. How do you navigate this and make sure that you're not misdiagnosing?
Sure. I think that the thing is, well, as someone who's not a TikTok user or subscriber, I'm never going to be able to sort of specifically question what it is that they saw. But I start with that simple question of, hey, what was it that you saw or heard that made you concerned about this? Have you done any further reading? And usually it's pretty easy to understand what it is that the concern is. It's rare in my experience that people are off the mark when they've come in with those concerns. And then I think it's a matter of starting with the specific concern that came about as of watching something online, and then expanding that into, well, what are the other, into the questioning around the other criteria of ADHD, be it through your own knowledge or one of those standardised questionnaires.
Absolutely, James. Thank you so much for coming in for what was a really fascinating chat. Thanks for joining us on sMater. But before you go, we have something we like to call the checkup. So Maria has 5 quick questions to ask you. This is just about finding out more about you, James, the person.
Yep.
James, if a genie could grant you one wish, what would it be?
Only one wish. Okay, it's the first thing that comes into my mind. This is something I fantasize about, and there is a discovery made with respect to the neurobiology of human beings, which makes us far less self-centered, horrible, paranoid, and destructive.
I think it's the first time we've heard that, and that is a cracker, James. That's fantastic.
Who was the last person you FaceTimed?
It would have been one of my parents. I think my son was trying to FaceTime my sister last night, but it would have been my mum and dad.
If you could impart one piece of knowledge on a medical student, what would it be?
My advice would be keep going. You'll get there. If you are right for the thing that you want to do, you will get there. I think with respect to advice, probably comes out of my area of work here at the Mater, and that is, don't ever assume that someone with a disability doesn't have the conditions that are going on in all of us, i.e. the mental health conditions that happen in all of us, because I see that sort of dismissed on a regular basis, and or health conditions missed because the time is not taken to really look at that person and find out what might have gone wrong, and address it when there is a major developmental disorder or intellectual disability present.
Very good reminder. And what was your first concert?
Yeah, I got wind of this one. It was either the baby animals at St Paul's Terrace Hotel.
Paul's Tavern?
St Paul's Tavern. I don't think it exists anymore.
Not sure.
It's there. The building's there, but I don't think the pub is.
No.
It was either that or the Cranberries at Festival Hall.
How do you want patients to see you?
Broad question. Look, I would hope that they see me as someone who is accepting and helpful, but willing to tell them the things that are unnecessary, which is sometimes tough or unpleasant. And I try and sort of cushion it with humour.
Perfect. James, thanks again for joining us on sMater.
Thanks for having me.
For our listeners at home or in the car or enjoying a well-deserved break, thanks for tuning in.
See you next time on sMater.